Dear friends, emergency physicians across the world, and Yashoda family. On behalf of Yashoda family and the Society for Emergency Medicine India and the Association of NBE accredited hospitals, we welcome you to this webinar on environmental emergencies, heat, cold, altitude, and beyond. And we have the most eminent speaker today, and none other than most of you are known to him in one way or the other. He's my very close friend, Professor Dr. Tamorish Kole. We started our journey way back in 16 to 17 years back as members of society, and we took it forward. He had been in many positions of the Society for Emergency Medicine India, secretary, joint secretary, vice president, president, mentor to many people. He was one of the advisory board members for the National Board of Examinations. He is currently the technical advisor for Emergency Care Services, HSSC. He is the chief functionary and board member for Heart and Stroke Foundation of India. He is also the immediate past president of Asian Society of Emergency Medicine and the visiting professor of University of South Wales, UK. And is the chair of disaster medicine. And he has been published many white papers on this climate change, and he has changed totally into climate man. Recently, about 2 years back also, everybody had written a white paper on climate change and became a very huge success. And he's been authored in one of the disaster life support, which was been honored and been released by our Prime Minister of India. And he's the Taskforce for WHO, and he's an alumnus for USA. With these few things, there are much more publications, everything, whatever you name, it's there. We welcome you, Professor Dr. Tamorish Kole. It's over to you.
Thank you, Dr. Srinath. And Srinath, and me are working for many, many years now in emergency medicine. And I think whatever we do, in wherever position we reach, we are always student of medicine and to our specialty emergency medicine. And I appreciate Srinath and Yashoda Hospital's effort, as well as with Anbai and Society for Emergency Medicine, to reinvigorate the academics of emergency medicine in the form of webinar. And I have been watching it for some time. It's on different important topics. The webinars are organized, and it's very well organized, so to say. And it is always a two-way process. While I will be speaking in this webinar, rest of the webinars which I attend, I keep learning, and that's the motto of everyone, I guess, who is watching this webinar series. So without wasting time, I will share my presentation. Yes. I hope you can see my screen.
Yeah, we can see your screen. Thank you.
Okay. So as Srinath said, my current interest lies on climate change and emergency medicine. And when he has given me a list of topics, I took no time to select environmental emergencies, because it is far more important today than before. And as I speak, we will be explaining how we will be able to deal with more and more patients, citizens who will be encountering environmental emergencies. And I have selected 3 out of many, which is heat, cold, and altitude. Srinath already introduced, so I bring greetings from Heart and Stroke Foundation of India, Society for Emergency Medicine India, Asian Society for Emergency Medicine, and International Federation, as Srinath explained. So before we go directly into the core emergency medicine topics, we'll quickly go through some of the basic concepts which we need to always keep in our back of our mind while we discuss heat, cold, and altitude environmental emergencies. So just to set the context, death due to heat stroke in India is rising. If you see this figure from 400 in the year of 2001, which is almost touching to 1400 This is about male sex, which are much more exposed to heat and working outside, and then their professions demands them to work outside, and they are more prone to heat stroke. So this is just to say that it is increasing. And of course, in female sex, although the number is low, but still the incidence is increasing. So we are started living in an altered climate, which in India, at least, we are facing a lot of heat emergencies. And we will discuss that clinically as well. Now, the first thing is, before we go into the core diseases or core phenomena, we must remember some of the basics of thermoregulation. So as we all know, the human beings or human species, we are homeothermic animal. That means our temperature inside the body is maintained at a particular level, and that's it. That is because of our body function, cellular function, enzymatic function, and things like that. And that temperature is maintained through hypothalamus, which is sitting inside brain, and peripheral thermoreceptors. And it is maintained through, simply put, it is maintained through a balance between heat production and heat loss. So that's what is the fundamentals of thermoregulation. So if the body temperature rises, for example, if we are going in a heat or hot summer, what happens? Our blood vessels dilate, resulting in heat loss to the environment. Sweat glands also start secrete fluid, and that fluid evaporates and heat is lost from the body. And heat is lost to the environment, and we maintain normal body temperature. Conversely, if the body temperature falls, then the blood vessel constrict, so the heat is conserved. Sweat glands do not secrete the fluids. Shivering, which is involuntary contraction of muscles, generate heat, which warms the body, and heat is retained. This is in a very, very basic format how the body temperature is maintained if there is a heat or cold in the environment. Now, as I started telling that we are started living in a new normal. COVID has brought a new normal, but our climate has also brought a new normal. So in the new climate which we have started living in, we have started seeing less cold weather and more hot weather. And when we talk of colder days and the hotter days, they are becoming shorter and they are becoming more harsh compared to the previous climate. So the effect of heat and cold is becoming stronger. It is becoming, coming in shorter spells, but coming frequently. And in addition to the mechanism which I mentioned, there are also effects due to radiation, especially the solar radiations and greenhouse effect and things like that. So today's maintenance of temperature in our body is not simply through heat balance equation, which is the heat production and heat loss. There are other factors as well, which is beyond the scope of this presentation. But just to summarize that there are other factors because of climate change which has started affecting our body temperature. Now, heat and cold-induced injury results from increase or decrease in the body temperature outside the normal range. So the mechanism fails, or due to prolonged efforts to compensate. So these are the two main factors through which heat and cold-induced injuries come. Now, from these basics, I want you to also learn a very, very important concept from weather physics, which is called wet bulb temperature. In simplification, the wet bulb temperature accounts for both heat and humidity, unlike the standard temperature measurement we see on weather apps. Now, why it is important? It reflects on what that combination means for human body's ability to cool down. For example, if there is a heat, say 35 degrees centigrade, but the weather is humid, then the effect of that heat because of the high humidity is much more than, say, temperature is say about 40 degrees but there is very less humidity. So the effects are too different. Therefore, when we talk about heat effects on human body, we must factor the wet bulb temperature, and we should not only depend on the crude temperature measurement which we can see all the time. It gets quoted in television channels or weather apps. So physiologically, wet body temperature is very, very important. Now I'll switch on to heat-related illness to start with, and then we will do cold, and at the end we will speak about altitude. Now there are three basic symptoms and signs of heat emergency. We group them into heat cramp, heat stress or exhaustion, and heat stroke. Heat cramps are generally muscle cramps. It happens in normal to mildly elevated temperature, and there are a lot of sweating which accompanies heat cramps. Heat stress, symptoms of which is seen in heat cramps, plus the body temperature gets elevated, normal to elevated temperature, but the temperature remains below 104 degrees Fahrenheit. In our country, we mostly use the Fahrenheit as body temperature measurement. And it accompanies with symptoms of nausea, vomiting, headache, malaise, and dizziness. And there is also sometimes, orthostatic hypotension found in patients. When you see in heat stroke, these are symptoms of heat stress, plus the body temperature now crosses 104, and most important is it accompanies with neurological abnormalities like inappropriate behavior, confusion, delirium, sometimes seizures, ataxia and coma, and there is either anhidrosis or sweating. And this is actually from our textbook, so you can find a reference there as well. Now to start with heat cramps, what happens pathophysiologically? Hot environment causes profuse sweating, the sodium is lost in sweat, and lack of sodium causes the muscle cramping. And this we often see, especially in hot environment when people do exercise, long runs and things like that. Heat cramps do set in. Also account the humidity and wet body temperature when you are thinking about heat cramps. So what happens? Generally, we found cramps in fingers, arms, legs, and abdominal muscles. Sometimes it accompanies with nausea, mild hypotension, cool but pale skin. The patient is, however, awake, alert, and the body temperature is normal. And that is what it differentiates from rest of the two heat emergencies. How to manage? Very simple. Move to cool place under the shelter. It may not be air conditioned as it may not be found all across the country. You just need to move the patients in cool place. Ask he or she to rest and lie down, and give the balanced salt or water solution. Salt alone leads to increased nausea and increased water loss, so you have to mix it with water. And water alone can lead to worsen cramping. So do mix salt and water when you are trying to manage heat cramps. If the heat cramps is not managed by oral fluids, the patient is vomiting, then you can use IV normal saline or lingeracted. Avoid massaging muscles. It does not help. Avoid activity. Increase fluid and salt intake. So very basic and easy management. I think it's possible anywhere where the health facility is there. When you come to heat exhaustion, pathophysiologically, it is due to increased vascular space due to vasodilatation, decreased blood volume due to sweating, and decreased CNS perfusion. Now, who generally suffers from heat exhaustion? People working in hot and humid environments. And as we saw, the male sex is more prone because they are the ones who are mostly in hot and humid environments. Elderly, due to decreased heart mechanism and other comorbid conditions. Hypertensives due to medication effects. So they are the ones who are prone to heat exhaustion. Signs and symptoms, as we described before, it accompanies headache, dizziness, fatigue, sometimes weakness of syncope, profuse perspiration and pallor. Tachycardia and hypotension can set in. You can also find orthostatic changes and normal core temperature. Management again, move to cool place, stop activity, lie down, supine, legs are elevated, sponge with cool water, fan, balanced salt or water solution, or with IV normal saline, and assess the glucose level if there is altimeter status. And transport this patient if there is loss of consciousness, because they may be switched on to heat stroke, underlying cardiovascular disease, and while you are transporting, you can put the patient on oxygen, ECG monitor if the transport is indicated, and we will go back to this ECG when. Now, when we talk of heat stroke, that is pathophysiologically the body heat accumulates, which leads to increased temperature above 104, generally 105, 106, that range. Increased temperature damages the hypothalamus. So what happens? Heat regulating mechanism fails, and it has got 25% to 50% mortality. So we have to prevent the patients to come to the heat stroke phase or treat aggressively. Two choices. Now, types of heat stroke. Firstly, let's discuss on exertional heat stroke, which occurs in healthy young people in hot environments. Heat builds up faster than it is removed and damage to hypothalamus, and patients sweats heavily. And there is a classical heat stroke, which actually happens on elderly, obese, heart disease patients, alcoholic, and the people who are on phenothiazine kind of drugs. Here, body heat builds up slowly over several days, and there is dry skin and absence of sweating. So this is how it differentiates between the exertional heat stroke and the classical heat stroke. Absence of sweating versus presence of sweating. Now, signs and symptoms: headache, dizziness, irritability, decreased LOC, altered mental status, very much common, bounding pulse progressing to rapid wake pulse, and hypotension. Now, presence or absence of sweating is actually not a very reliable sign. We need to assess the patient in totality. In management, we need to secure the airway, high concentration oxygen to be given, rapid cooling to temperature below 104, preferably 102, that range, IV with normal saline, ringer lactate. Now, avoid volume repletion in classic heat stroke, and exertional heat stroke may actually need volume replacement. And always monitor ECG. Sometimes we need drugs, for example, glucose for hypoglycemia, diazepam for seizures. So if you want to quickly control, you can use other antiepileptic drugs as well. Secondary complications. Do remember cardiac dysarrhythmias and pulmonary edema. And be careful while transporting this patient. Now, there are various cooling techniques which are available today. Just quickly go through some of the methods. Evaporative cooling, which provides effective cooling, readily available, practical, and can cause shivering though, but it is strongly recommended. Immersive cooling, where it also provides effective cooling, but also can cause shivering. It is poorly tolerated. Ice packs on neck, axilla, and groin. This is practical. Can be added to other cooling methods. Cooling times is longer and can be used only as an adjunct cooling method. Sometimes cooling blankets are used, is easy to apply, have limited cooling efficacy, not recommended when other methods are available. Cardiopulmonary bypass, however, very complicated, but provides fast and effective cooling, recommended only in severe and resistance cases when available. And the other methods like cold water gastric lavage, urinary bladder, rectal or peritoneal lavage, it is again advocated to cool the core when cardiopulmonary bypass is not desirable or possible. It is invasive, labor intensive, and human experience is required to do this. However, this effectiveness and safety is not well established. So stick to evaporative cooling, immersion cooling, and try to add ice packs on neck, axilla, and groin. These are the top three are most practical methods based on the resources of our country. Now, similar situation, similar syndrome can also be present, which should be considered on differential diagnosis of heat stroke. Infections such as meningitis, encephalitis, malaria, especially in our setup, endocrine, pheochromocytoma, thyroid storm can cause, neurologic, like hypothalamic bleed, status epilepticus, and toxicology, such as serotonin syndrome, malignant hyperthermia, neuroleptic malignant syndrome. Sometimes alcohol withdrawal can also cause heat stroke-like symptoms. So this has to be considered in case there is a doubt. There are several complications of heat stroke, however. We described hypotension, we described shivering, but it can lead to rhabdomyolysis. Neurological, it can cause seizure, and lately it can cause cerebral edema, encephalopathy. In cardiac, it can cause early heart failure and late myocardial injury. Pulmonary edema can be setting in. Renal, it can quickly lead to oliguria, and in long run, it can lead to renal failure and rhabdomyolysis. Pancreatic injury, hepatic dysfunction, etc. Metabolic, several complications, mainly hyponatremia, hypokalemia in the initial phase, and hyperkalemia and hypocalcemia in the late phase. That has to be remembered. And in the late phase, hematologically, thrombocytopenia and DIC can set in. So if not treated, it can lead to several lethal complications. That's why we need to treat it aggressively, and mortality, clinically documented mortality is 25 to 50% on heat stroke patients. Switching on to cold-related illness. Cold-related illness, again, divided into two category. One is local cold injury, and the second one is generalized cooling. Now, the first injury generally sets in, the more common injuries are local cold injuries, and we must remember this. The local cold injury, again, are divided into two types: non-freezing, which are chill, blains, and trench foot, and freezing, which is frost nip and frostbite. Okay, so let's see what are these. Chill blains is caused by chronic exposure to damp but non-freezing ambient temperature. These are painful inflammatory lesions on the skin. The common sites are hands, ears, lower legs, and feet. It can cause pruritus and paresthesia. Now it tends to recur, please remember. So treatment, generally, we say rewarm, bandage the parts and elevate it if possible. Now switching on to the next injury, which is trench foot, which is caused by prolonged skin exposure to cool and wet conditions. Generally, therefore, it is found on feet which are exposed to colder weather as well as wet conditions. Skin becomes pale, mottled, and anesthetic. You don't feel it. Sometimes sloughing and gangrene may occur. Now, the treatment is clean, warm, and dry bandage elevation is required. Frost nip or frostbite, it's a local freezing of the tissue. Commonly affected areas are toes, feet, hands, fingers, nose, and ears. So this is the third entity which we're doing, frost nip. The risk factors are poor clothing, poor nutrition, diabetes, and decreased tissue perfusion. Please remember tight clothing. Vasodilatation from alcohol and medications. And then factors that increasing the likelihood of frostbite, which is environmental, low temperature. There's a long list which is there in the textbook. You can read it. So switching to frostbite, there are stages of frostbite. Pathophysiologically, the phase 1 sets in due to exposure of cold, vasoconstriction, decreased blood flow to the periphery, ice crystal formation in extracellular space, ischemia, and then cellular dehydration or hyperosmolality. It can also lead to edema, increased pressure, blood vessel damage, and that can set up worsening ischemia, and that lead to cellular destruction of the cellular components. And if the tissue is rewarmed, blood flow returns, the damaged capillaries leak fluid, and the swelling occurs. So there is a biphasic effect on pathophysiology on frostbite. In frost nip, extremity appears pale and discomfort is present. No extracellular ice crystal formation can be seen. Symptoms resolve or on rewarming, and tissue loss does not occur. But in frostbite, there is a chance of tissue loss. And there are 4 degrees of classification clinically. First degree is numbness, central pallor with surrounding erythema and edema, along with dysesthesia. Second degree is blisters will set in the skin and surrounding edema. Third degree, tissue loss involving the entire thickness of the skin and we found hemorrhagic blisters. And fourth degree is tissue loss involving the entire thickness of the part, including deep structures, resulting in the loss of the part. And extent of the injury frequently cannot be determined due to that biphasic nature of the pathophysiology until the rewarming occurs. So these are some examples of first degree: partial skin freezing, redness, mild edema, lack of blisters. Second degree, you can see substantial edema and formation of clear blisters in the hand, which was shown here. And then third degree, which is full thickness, subcutaneous freezing, hemorrhagic blister, necrosis, which can set in. And in the fourth degree, you can actually see the damage of muscles, tendons, and even bones. Initially, they become mottled and cyanotic. Eventually, they are dry, black, and mummified. So treatment of the frostbite, the core treatment remains immersion in or application of water, which is warm, which is 37 to 39 degree until the affected area is pliable and erythematous, and do not begin rewarming until the risk of refreezing is eliminated. Then parenteral narcotics for pain management, topical cream can be applied. Don't forget tetanus immunization, and for pain control, oral NSAIDs can also be used. Post rewarming, you can see pulse deficit because of the swelling. Prevent the refreezing, assess the local frostbite management expertise can be considered. And sometimes you can consider IV or intra-arterial thrombolytic therapy only by institutional protocol. So if the patient needs to be transported, and generally frostbite happen at the site which is very, very cold at higher and remote locations. So if you are anticipating short transport, then consider ABC. Protect the affected area, bandage, and avoid rewarming. Prevent and treat hypothermia, remove the wet or constrictive clothing, dry the patient and warm the IV fluid, and you can transport with minimal analgesics. But if you're anticipating long transport or rescue, long rescue, then remove the patient from the cold, remove clothing from the affected area, then you start rewarming until flushing or tingling is present in the skin. Dry gently, bandage the extremity, and treat the concurrent hypothermia and analgesia for pain. Do not, you must remember these don'ts. Allow refreezing, massage the injured part, allow the patient to smoke, and puncture or drain the vesicles of the bloods. Now coming back to hypothermia, which is set in when the core temperature is less than 95. It may be caused by decreased heat production or excess heat loss, and various other associated factors like environmental temperature, energy, there's the nutritional status, food and water status, and ambulatory ability. Risk factors, therefore, are extremes of age, those who are in outdoors, those who have hypothyroid, diabetes, hypoglycemic patients, people who are using alcohol, using depressant drugs, and poor nutrition. Signs and symptoms of hypothermia is it starts with pallor or shivering, then the gait disturbance, which is become ataxic, and then the altered mental status sets in, apathy, drowsiness, coma, slowing pulse rate, and finally cardiac arrest. So if there is an altered mental status and there is cool environment, think of hypothermia. Now ECG changes mostly late, so don't wait for them to set in. And however, if you find they are a poor prognosis, the first thing is bradycardia, and they are possibly unresponsive to atropine. Then either the small or absent P wave, abnormal STT changes, and finally J wave or Osborne wave. So this is J wave. J wave is defined as a positive deflection seen at the J point in precordial and true rim blitz. However, please remember in ABL and V1, the J wave or the Osborne wave, which you can see here, will be negative deflection. So in all the leads, it will be positive deflection at the J point, but in the AVR and V1, it will be negative deflection. So that's how we discover J waves. However, these are late changes. Management, we all know mild core temperature when 90 to 95, moderate core temperature in 86 to 89, and severe core temperature is less than 86. This is important to remember because the treatment will vary according to the core temperature. Mild hypothermia, handle gently, prevent the further heat loss, insulate from cold, add heat to head, neck, chest, groin, and warm oral fluids after uncontrolled shivering stops. So these are treatment. Moderate, prevent further heat loss, remove wet clothing, cover with blankets, avoid active rewarming here, and then IV with normal saline and monitor ECG. Severe, however, requires securing airway or assist ventilation sometimes because of altered mental status. Do not hyperventilate, avoid rough handling, prevent further heat loss just like other two entities, ECG, IV with normal saline, and internal rewarming only. Okay. In hypothermic cardiac arrest, which we'll discuss also in detail, a little bit detail, if the core temperature is less than 86, shocks, limit 3 shocks, no medications. If more than 86, then increase the drug dosing intervals and repeat shocks as the core temperature rises. So the dictum is resuscitate aggressively and give little consideration to terminate the resuscitation effort. That means you continue for a long time. So that's why it is said you are not dead until you are warm and dead. So aggressively resuscitate and resuscitate for a long time. This is the current algorithm of managing hypothermia, is again from our textbook. So you can study it in detail. However, I just need to draw your attention that if there are no vital signs, today we also have option of starting ECMO, which is indicated when core temperature is less than 32 degrees centigrade and serum potassium is less than 12. And however, that requires again experience and ECMO centers to do this. However, that option is available today compared to, say 10 years back. It was not that much prevalent. However, today we have available facilities for ECMO even in India as well. Now, lastly, we will discuss about altitude sickness, which is again a very important topic to consider. Now, physiologically, what happens is when you fly on an aeroplane, actually the commercial aircraft are pressurized to an altitude equivalent to say 1,500 to 2,500 meters. Now, this is very safe, so nothing happens to us. However, you go above the altitude of 2,500, then there is, and if you are in a cold weather and you are trekking up in altitude, you can develop alternate metastasis and a high altitude cerebral edema. Then your complex reaction time slows, psychomotor impairment becomes difficult. Then when you go at a very high altitude, the learning and spatial memories are impaired. And you go above that, say at a height of Mount Everest, then about 32%, even the best of the climbers will have hallucinations. So these are physiological effect. And if you can see on the left side, the correspondence drop in the PO2 at a level of 40 at the altitude of say 9,000 meters. So these are important things which we need to consider for physiological changes. Now in high altitude, say about 5,000 feet to 11,500 feet, there's a minor decrease in oxygen transport, which is a CO2 more than 90%. Altitude sickness, which is common with rapid ascent, above 8,200 feet. In a very high altitude, the maximum SaO2 is less than 90%, most common range for serious altitude sickness. And in extreme altitude, such as 18,000 feet, for people who are not acclimatized, severe hypoxemia, hypocapnia can set in, and deterioration will outstrip the acclimatization. And in top of Mount Everest, unacclimatized person, those who are not trained as climbers, those who have not climbed before, they will be unconscious in 45 seconds. And they will drop dead in 4 to 6 minutes, just by the effects of altitude. So the effects of altitude physiologically is very lethal if we do not follow the rules and do not get accustomed to acclimatization. So it's not everybody's cup of tea. Now in altitude physiology, if you see, there is, when you go up, there is hyperventilation to compensate for decreased FiO2, which leads to alkalosis, and that suppresses the breathing, especially during sleep. And then episodic respiratory arrest, which happens during sleep. And then if it continues, it leads to hypoxia, vasodilatation. Vasodilatation leads to increased cerebral blood flow, and that results to HACE, which is high altitude cerebral edema. And at the same time, it also results in increased capillary permeability, which also results in cerebral edema, and that can also result in HEP, which is high altitude pulmonary edema. So that is in simple, and sometimes it can also lead to peripheral edema as well. And that leads to increased risk to cold injuries, which we were studying just 5 minutes before. So that's what happens. So in mild acute mountain sickness, we found headache, dizziness, malaise, which is dyspnea on exertion, anorexia, dry cough, nausea and vomiting, and decreased urine output. Any alternative symptoms are due to altitude until proven otherwise. That's the dictum we usually follow. Now we go a little bit higher up, high altitude pulmonary cerebral edema, which is HACE, sets in, which is demonstrated by headache, mental dullness, ataxia, and focal neurodeficits in terms of paralysis, paresthesia, and things like that. And so, if you do an MR, if the facility is available, you will find edema in various parts of the brain when this syndrome sets in. In contrast, HAPE, which is high altitude pulmonary edema, which generally manifests as dyspnea as rest, fatigue, weakness, orthopnea, sometimes hemoptysis with blood tinged sputum, and finally cyanosis and rales. And if you can do a chest X-ray, you can find pulmonary edema, especially when you come down. So the first treatment is stop ascent. And at the same time, remember, when you descend immediately, if no improvement with treatment and ataxia, decreased loss of LOC, level of consciousness, and pulmonary edema sets in. Do not exert minimum exertion and bed rest. And I just put this photo of Dr. Imran just to say that people really need to be acclimatized to reach to a summit. So in this case, Imran is at an altitude of 15,781 feet, and he's holding the society flag. He doesn't demonstrate any signs of altered mental status, so hopefully he's not suffering from any of this. However, if we are not acclimatized and if you go to those high altitude, things can really go wrong. Again, from HAPE treatment point of view, oxygen and treatment of pulmonary edema, like CPAP, there's possible application of hyperbaric chamber. It's a non-cardiogenic pulmonary edema, so there's no role of Lasix or morphine. And sometimes for cerebral edema, we use dexamethasone. So these are medications which we generally use for HAPE and HACE. The mainstay of medication is acetazolamide, 125 to 250 milligrams twice a day, beginning 24 hours before the ascent and continuing during ascent and for at least 48 hours after arrival at the highest altitude. This is the dosage pattern. Indications: adverse effect do include paresthesia, polyuria, and can be taken episodically for symptoms like speed acclimatization. There is no rebound effect. However, in pregnancy, do avoid in breastfeeding. If you want to treat altered mental status, then dose of acetazolamide is increased to 50 milligrams per oral every 8 to 12 hours. Dexamethasone, as I previously indicated, it is used for treatment of altered mental status, 4 milligrams every 6 hours, or for treatment of HACE, which is 8 milligrams initially and then 4 milligrams every 6 hours. Tadalafil, which is a venodilator, can be used 10 milligrams per oral twice a day, again starting 1 day prior to ascent and continue 2 to 4 days at maximum sleeping altitude. Nifedipine is also used for treatment and prevention of high altitude pulmonary edema. 20 to 30 milligram extended release preparation per oral every 12 hours, or for treatment 30 milligram extended release per oral for every 12 hours. So these are the choice of medications to deal with acclimatization as well as HAPE and HACE. Now, in conclusion, I would like to say we have today discussed problems with heat, problems with cold, and the problems with altitude. But the effects of environment, especially the altered environment, the effects of climate change is much more. And that will probably require one more episode to discuss the bigger picture. But today is the foundation where we discuss heat, cold, and altitude. So it can, the altered environment, which we discussed during climate change and things like that, can alter our medical and physical health, heat-related illness, allergies, today we did not discuss, increased exposure to waterborne and vector-borne illness, and in a place where it was not found before because of the change of climate, a lot of emphasis on mental health because of increased effects of climate, issues with food security, and issues with conflict. stress, anxiety, depression, post-traumatic stress, increase in substance abuse that is growing. And then, of course, community health, which is increased interpersonal aggression, increased violence, social instability. These are all effects of that altered climate, and it is much more beyond just heat, cold, and altitude. And that is where we will have some other day, we will discuss on this dimension as well. So we must understand that heat, cold, and altitude is no longer a simple task. These are all part of the small entity, but the bigger canvas is all about climate change and global health. And we as healthcare leaders and especially as a specialist in emergency medicine has got a lot to do with the effects and the steps to encounter and treat successfully on all these patients and situations. And this is the summary, and I would like to quote Rini Salas, who is an emergency physician, and she has worked on this intersection of heat, cold, altitude, climate change. And she said, and I quote, our specialty in emergency medicine was bred out of a necessity to deal with trauma, NCDs, and things like that. And this necessity to address climate change actually falls on us. And we have never shied away from a challenge. And therefore, we must rise to meet this one. And this might be our greatest yet. Thank you very much.
Thank you very much, Professor Tamorish. It was enlightening and eye-opener for all the residents, consultants who are listening to your lecture. And climate change is the most important factor which we are all facing. Some days it is very cold, some days it is very hot, as we are all seeing. The floor is open for questions to Dr. Tamorish to take up any questions. Naveen, any questions are there?
Yeah, nothing in the chat window. I'm just asking some, if they have, they can post.
Anything in the Facebook?
Just a second. Someone posted a question.
Yeah. Heat stroke treatment.
I think I have discussed in detail about heat stroke treatment. Yeah, so just I think I will email the slides and you can share with the participants. So the basic principle is that you need to treat aggressively and treat fast. And the second principle, which I mentioned, that do not allow the patients to pass into the phase of heat stroke. Identify and treat in the phase of heat cramps and heat exhaustion. And third, most important, is identify the people who are vulnerable and try to advise them preventive measures, those who are working outside, elderly, patients with diabetes. You need to be very, very careful.
Thank you very much. Any other questions?
One more. Yeah, that's been answered.
Yeah.
No other questions. In the meantime, we have this course coming up, that is Rapid EM Review. That's especially curated for the upcoming exam. So if you're giving the exam in the end of January, this will be a very good chance to revise all the core EM topics. So the faculty will be from all over India, eminent speakers. So make use of this opportunity, and if you're interested, get back to us.
Is paracetamol helpful in heat stroke?
No. That is what I have also described in my presentation.
Correct.
So here the mechanism of controlling temperature is lost. So the effect of paracetamol will not be helpful here. So cooling is the choice, not paracetamol.
Any alternative for acetazolamide in mountain sickness?
Sorry?
Any
Any-
alternative for acetazolamide?
So I did describe the vasodilators, selective vasodilators. Tadalafil is helpful.
Yeah.
And next week, we'll be having one journal club discussion. We'll be having 3 teams. They'll be discussing about 3 studies specifically. That is SALT ED, SMART, and Basics. So do join us next week. So if there are no questions, then you can end this.
On behalf of Society for Emergency Medicine India and the Association of NB accredited hospitals and Yashoda hospitals, we wholeheartedly thank Professor Dr. Tamorish Kole for spending his time in this webinar and giving the valuable opinion on the most important topic today, which has been spoken across the world. And it's become a hot topic with all the major nations who are discussing. If you have missed out to visit this on live, it is always there on Facebook. You can go back and see to it. And if there are any questions, you can type in the Facebook. So we'll contact Professor Tamorish and get back to you. Thank you very much.
Thank you.
Thank you.